All right. So, sometimes I have to confirm. Sometimes I just talk to myself. So, uh, all right. Okay. So I have 1 hour to deliver this talk. So you could see my slides, and the title is Epidemiology and Coronavirus Disease 2019. So my name is Kamarul Imran Musa. I graduated from USM, and now I'm the associate professor at the School of Medical Sciences, USM. Um, a little bit of disclaimer. So I'm not an infectious disease physician, all right? So, and I don't consider myself as infectious disease epidemiologist. Um, I have done a little bit of work with typhoid, dengue, HFMD, and malaria when it comes to infectious disease. But most of, or more, or a significant proportion of my work concentrates on the non-communicable diseases. So the presentation is based on my personal view. So I'm very sure that I could be wrong in some of the presentations and data. I would like to bring you through this, workflow. First we'll talk about epidemiology, definition and interpretation, and then we go to progressions of COVID-19 pandemic, and then we'll talk about reproduction number, because everyone is interested in reproduction number, and we go a little bit more deeper into compartmental model, which is one of the models important for epidemiologists now, and we will look at some of the modeling tools for epidemiologists. Um, right, I forgot to tell you that I've got the slide ready for you if you want to download in PDF format. So just go to bit.ly USM for COVID-19, right? So USM for COVID-19. So that's the link where you can download the slide, bit.ly slash USM for COVID-19. When we talk about epidemiology, so epidemiology means the study and analysis of the distributions, who, when, and where of diseases. Epidemiology itself means the study of what is upon people, and it is derived from a Greek word. Epi means upon or among. Demos means people or district, and logos means study, word or discourse. Um, for formal definition of epidemiology, this you can consider as the modern definitions of epidemiology. So again, it is a study, a systematic, a scientific, data-driven kind of study, where we look at the distributions. What kind of distributions? The frequency, the pattern, and identify the determinants, causes and risk factors of health-related states. And also events, not just diseases, all right? Also events, like tobacco smoking and substance abuse, and all that in specified populations, neighborhood, school, city, state, country, or global. And one important thing that people always, or tend to forget is that the epidemiology also means the application of the study to the control of health problem. You apply the informations and to control and prevent diseases. The modern epidemiology, perhaps, you know, um, was popularized by John Snow. Everyone, I think, knows John Snow, where he investigated the causes of 19th century cholera epidemics in London. where he noticed that significantly higher death rates in two areas supplied by soft work company, and because of his what we call as shoelace epidemiology, he walk around and identify where and how possibility of spread of cholera. Then he managed to identify that the Broad Street palm was the cause of the Soho epidemic. And so epidemiologists are basically, disease detectives. Okay, we investigate diseases, and not just diseases. Again, I have to remind you that it's also about events, risk factors and all that. And epidemiologists study patterns and determinants of health and diseases in a defined population. Okay, the objectives are to search for the cause of disease and risk factors, to identify people who are at risk, and then determine how to control or stop or prevent the disease, and apply findings to again to control and prevent the disease. So there are aspects of finding the causes, understanding the problems, and then applications of that knowledge and data to control and prevent the disease. Now, let us go to pandemics. All right, let us go to pandemics. If you look at the this chart, for example, you'll understand that um, COVID-19 pandemic is not the first pandemic in this century. All right. Um, can I say a century because it's already the year 2000, right? 2000, 1000, 1900. Okay, in the last 100 years, for example, right? Because we have 1918 flu, which has killed 15 million people. We have Asian flu. We got Hong Kong flu. We got SARS, of course, in between 2002 and 2003, which has killed less than 1,000 people. We got MERS COVID, if you remember, in 2015, less than 1,000 people died. Um, Swine flu and Ebola. Ebola, I think everybody knows about Ebola. Has killed about 11,000 people. Um, and COVID-19, at that point, where when I took this graph, it was in April 6 last year. So it was at 71,000 deaths. and and remember or don't forget that we have HIV and AIDS, which is also a pandemic, which has killed around 50 million people. If you look at the 15 large pandemics, okay, with at least 100,000 deaths, um, then you could see the list of that contain Black Death in between 1347 to 1352, which killed almost 75 million people that time. So 75 million that time was a huge number. Okay, maybe one quarter or one half of total Europe was wiped out because of Black Death. And then we got Italian plague, Great Plague of Seville, Great Plague of London, Marseille, Russia cholera pandemic, global flu pandemic, sixth cholera pandemic, Spanish flu, Asian flu, Hong Kong flu, H1N1 pandemic. So uh, you know, after 1900, we got one, two, three, four, five. At least five pandemics. So it is not something that uncommon, I think. All right, and we know that what causes COVID-19. So this is for the benefit of maybe people who wants to know more about coronavirus. So it is a virus that comes from a large family of viruses. It causes illnesses in animals and humans, and humans coronavirus that have known to cause respiratory infections, for example, like Middle East respiratory syndrome. There was quite a hoo-ha before this, right? In 2015, 2017, 2016, where people that were going to Hajj or were coming back from Hajj were screened for MERS-CoV, and then we got SARS, maybe a couple of times, and now COVID-19. So again, we don't know what actually, who, which animal that causes this. Even some people speculate that this is not, this is human generated virus. People engineer this virus, and then because of what we call spillage of this virus from lab to human, then it started to cause havoc. But we don't know at this point of time. All right. So one of the hypotheses is that uh, this virus came from bat, and that this bat can harbor at least three types of viruses: the SARS-CoV, MERS-CoV, and SARS-CoV-2, which then spill into civet, camel, and pangolin, and then from that cross to human. So that's one of the hypotheses, and the other hypothesis, which is quite interesting, is the spillage of this virus from the lab. I don't know. Okay, I don't know. I can't comment more on that. When we look at the COVID-19 in Malaysia, for example, right? It started on this day, February 4th, 2020. Okay, where in the Star, a newspaper clip that I put here. First Malaysian test positive for Wuhan coronavirus. Okay, last year, February 4th, only last year. So a 41-year-old man from Selangor, positive for Wuhan coronavirus. And again, this is the link of the slide. And in middle of February and March, you see, two positive cases, Malaysia, and we got 9 from China, with a total of 11 positive uh, cases for COVID-19. And then the, February, and then March, and then it was again one large event that took place last year, the Tablet gathering, and which somehow has helped the COVID-19 to spread like wildfire. And how is it now? Okay, in 1 year, 6 months, something, we got 198 million cases. I took this dashboard, the screenshot of this dashboard last night. 198 million, with 4 million deaths, over 4 million deaths, and the vaccination status as for last night, 4 billion people, no, 4 billion doses of vaccine have been administered. Again, if we look at the trend, we are somehow at the plateau phase. It is not showing any pattern of reducing in number of daily death or daily case. In fact, the daily cases is on the increasing side. If you look here, increasing side, and daily death has been stabilized. Okay, has been stabilized. But overall, if you look at this dashboard from John Hopkins, um, this a disease that we still have to be very very careful and delicate about. Okay, um, it is complex. It is not easy. It is fast spreading. So and nobody knows the exact answer on how to really uh, control and prevent it very effectively. Unfortunately, um, if you look at the timeline, okay, if you look at the timeline for epidemiologists, for example, right, when we look at a possible pandemic, if an outbreak happens, so the first thing that in February nobody knows it's going to be this large, for example, right? So so at that point of time, if you say to someone that it's going to be 100 million people will be infected, no, no, maybe it's a large number of people will not believe it, right? So so for epidemiologists, at the very early phase of epidemic, for example, we don't know, we don't know how big it's going to be, how severe it's going to be, right? So we could look at, we can break the timeline into maybe four phases. First, the very early of a possible epidemic, during epidemic, end of epidemic, and after the epidemic. Um, at the very early part of epidemic, epidemiologists need to be able to assess, a small outbreak, a small outbreak, whether it's going to be a potential epidemic, right? And later, if the epidemic potentially can grow into a pandemic, right? And at the same time, during the early part of the epidemic is to forecast to forecast the trajectory of epidemic, to forecast the trajectory of epidemic. And during the epidemic, okay, during the epidemic, maybe for like now, uh, the epidemiologists need to assess the time, place, and person who are affected by the epidemic, and look at the trend of infection, for example. Look at also the trend of impact of pandemic on the human lives. Death, comorbidity, complications, ICU, and all that. Look at the effect of the pandemic on the geography of people, a spatial and spatial temporal analysis. Look at where people are affected more, right? And identify who are people or population at risk. Okay, whether they are the elderly, the young ones, or whatnot. And perhaps assess also the fatality and the mortality. Um, Identify important indicators to reflect severity of epidemic. For example, now one of the indicators is the reproduction number, or R, but there are many more indicators that we can use alongside R to help us understand the trend of COVID-19, for example, better. And epidemiologists, have to assess the resources, okay, whether we got enough resources to contain or to accommodate uh, people who are infected, or people who, unfortunately move from less severe infections to more severe infections, to ICU and whatnot. We should have people or epidemiologists who should be able to tell us, what's going to happen in terms of resources, ICU beds, and things like that. At the end of epidemic, and following that, epidemiologists will look at the costing, what has the pandemic caused the human and also the non-human component, for example, the financial, the infrastructure, the societal impact from the pandemic. And we also, or epidemiologists need to also you know, I would say install, appropriate surveillance system, whether it is active surveillance system, whether it is passive surveillance systems, or whether it's a sentinel surveillance system, right? So those are, I think, the some of the activities that epidemiologists can do at different phases of an epidemic. Um, and to do that, people who are interested to to maybe to venture into epidemiology, or epidemiologists need to know some some knowledge, right? For example, the epidemic theory, where it is a branch of mathematics concerned with fitting statistical models. Okay, it uses empirically. It means that you use data from the incidence of communicable and other diseases. All right, so that's basically the epidemic theory. This was this term, epidemic theory, was coined in 1952. You look at the slide by F. Robert E. Suffling, Historical Review of Epidemic Theory. So it is an old paper, but you still can download this paper from, I think, JSTOR. Um, of course, um, you know, we got only one problem now. If we talk about pandemic, right, just COVID-19, but nobody knows what are the best way to contain COVID-19 effectively. All right. One of the answers is through vaccination. Yes, that's one. Okay. Even with vaccination now, there are concerns about breakthrough infections, about different variants, right? So, so it seems like we thought that we with vaccine that we should be able to stop the spread of infection, but it's too early to say so. Um, so one of the tools that that can help people or epidemiologists to monitor the trend of infection is to by looking at the reproduction number. So and in fact, I think nobody knows about reproduction number before 2020, and suddenly in late 2020, and now I think everybody knows about reproduction number, or R. Okay. So, so maybe we, can spend a few minutes to look at what is the reproduction number, how many types of reproduction number, or how can I estimate reproduction number. So, the reproduction number is also known as reproductive number. Is the number of cases, the number of cases expected to be directly infected by a single individual. This guy infected, then how many on average will he infect others in a population without underlying immunity? Okay, so this might be applicable at the beginning of epidemic, where there is no vaccine, everybody is exposed or susceptible to infection. So in epidemiology, R naught is the basic reproduction number, okay, or also known as the basic reproductive rate, okay. So it is the average number of cases directly generated by one case in a population, and one very important assumption there is that the population must be 100% susceptible to infection. So that is the definitions of R naught. Okay. So now, is it applicable, the R? Okay. So it's still applicable, but you have to be careful. Okay, you have to be careful. Don't use R naught, freely, okay, because it means something. So, what is the magic value for this R? For this R, of course, this one. Okay, if the R is above one, it means that um, the epidemic will spread. Because one person will, on average, infect more than one people. So, if R value is above one, then more people will get infected. If R value is less than one, it means that on average, less than one people will be infected in sequence. So the infection will slowly die off. If R is if R is equal to one, it means that the number of new infection will be similar every day. So it's going to be a constant number of infection. For example, let's say the average number of infection, the daily cases, daily new cases, 15,000. So if the R value equals 1, it means that tomorrow there will be 15,000, and then the next day will be 15,000, and so 15,000, 15,000, 50,000. So the R value equals 1 doesn't mean things is good. Okay, if the infection is like 10,000, R values of 1, it means that you will constantly get 10,000 new cases every day. Okay. Um, of course, the R value will depends on the rate of contacts, the probability of infection, and the duration of infectiousness. How fast people infect others, number one. Um, how what is the probability you infect others, and also how long you will continue to infect others, like 3 days or 4 days or 7 days. If you infect, if you know disease that is spread 7 days is much worse than disease that is spread within 3 days. Okay, that's for example. If you look at the attack rate, if you got the attack rate of 60%, it means that 60%. So if you got like 1 5 year, so we at the attack rate of 60%, you got the R naught value of 3. If you got attack rate of 40%, the R naught will be 2. And if the attack rate is 100%, if you got 5 people there, then you got R naught of 5. Okay. So, so that is another way. So this is another way of calculating the R naught value. So there are many ways. Okay, what I want to say is that there are many ways to calculate the value of the basic reproduction number. So this is one of the simplest one. If you look at the basic reproduction number for different diseases, um, Zika virus has got the R naught between 3 to 6.6. Okay, 3 to 6.6. Okay, one person will infect between 3 to 6 or between 3 to 7 people on average. Okay, one, and then the next 3 or 7, and then that guy will infect 3 to 7 people, and it will grow and grow and grow. Measles between 11 and 18. So measles have got very high infectiousness. Okay, Ebola 2, HIV higher than Ebola, 3.6 to 3.7, and so on and so forth. So if you know R naught, you can somehow calculate the proportion that you need to vaccinate. Okay, if you know the value of basic reproduction number, and that's what we call as the HIT, or the herd immunity threshold. Okay, the herd immunity threshold means the proportion of population that need to be immune, okay, to stabilize the spread of infectious disease. So when you have reached the value of HIT, then only one case will only lead to one other case. So it's going to be, so disease will stabilize. Infection will not get more, but infection will also not get less. It just that stays there. Okay, it stays there. So which actually means that R equals to 1. So if you look here, you have two infected people, and you got blue people here who are susceptible. Okay, so because of there are a large proportion of susceptible people, so this guy, the red guy, can easily infect others. But if you vaccinate, or if you give protection through immunity to these people, either through vaccination or through natural immunization, then you got more yellow people that prevent this red guy from infecting the blue guy. So you get stable kind of number of cases. So if you know the R naught value, you can just plug in the number here. For example, if let's say the R naught sorry, R naught for the R naught value for SARS-CoV at 2.5. Okay, it means that one person will infect between 2 to 3 people. Okay, just plug in the basic reproduction number here, 2.5 minus 1 divided by 2.5 equals 0.6. So if we use RO of COVID-19 as 2.5, it means that we need to vaccinate 60% of population to reach the HIT. Okay, so HIT is also known as the herd immunity. Okay, the proportion of population that reach the herd immunity. So this is one paper that I used. Why I used 2.5? Because this is one paper published in the, I think, Lancet, that shows the R naught for SARS-CoV was 2.5. Okay, so we need to vaccinate. For Malaysian, we need to vaccinate 60% at least if we use the R naught value of 2.5. But of course, that is simple mathematics. In real life, that might not be true. We got different types of reproduction number, not just basic reproduction number or R naught. Okay, we got effective reproductive number. What does it mean? It means that this effective reproduction number is the average number of secondary cases per infectious case, same like R naught, but in this in effective reproductive number, the population are made up of both susceptible and non-susceptible hosts. It means that those non-susceptible might be non-susceptible because they are vaccinated, or they got the infection already and now they are immune. Okay, so that's the difference between R naught and effective reproductive number. R naught and RE. Okay, basic reproduction number and effective reproduction number. Because effective reproduction number takes into consideration people who are susceptible and people who are not susceptible anymore. Okay. And then now, once we understand that, because that that concept, reproduction number, the spread of infection, is useful when we want to forecast or make projection of the infection. For example, to make projection of infection, to forecast the trend of infection, we can use what we call as compartmental models in epidemiology. Okay, compartmental models. The one of the simplest compartmental model is the SIR model. Okay, SIR model. So SIR model, where S stands for the number of susceptible, I stands for the number of infections, and R stands for number of recovered. Okay, so through some differential equation, then you can see how people move from being susceptible to infected, and from infected to recover, and whatnot. So this is one of the simplest model, the SIR model, that you can use now to project the trend of infection. Just now we talked about basic reproduction number to see how severe or how infective uh, is the infection or the epidemic. Now we have moved to compartmental model to forecast, to make forecast on the number of possible infection and other parameters. So this was developed in 1927. It's an old, an old model. So, some people have criticized SIR model because it is not a new model. It's an old model, okay, 1927. So, um, but we use that, okay. Our team, when last year, um, our team headed by Datuk Prof. Awan Bulgiba. So and actually, Mosti set up a team headed by Prof. Awan Bulgiba, and I'm one of the member under him. We call the team as the CEASE team, CEASE team, and we we use the SIR model last year. I think this was in March or April last year, and where we model what will happen to the number of infection, the number of ICU admission, the number of critical infection, the number of possible death for Malaysia, based on three possible scenarios. One, the worst impact case scenarios, moderate impact case scenarios, and optimistic case scenarios. So this was done uh, in April last year, I think, and we presented this to Mosti, and I think also to to Minister of the Mosti, Khairul Jamaluddin last time. So so this is an example how SIR model is useful for epidemiologists to forecast, because that was, this was like April last year, right? So nobody knows what will happen in June or in September or this year, right? So we presented this and we said that, okay, in the optimistic case scenarios, okay, very optimistic. If you don't do any intervention, we just let COVID-19 spread in community, then you have almost 2 million or 2.6, 2.7 million mild infection. And out of that, 230,000 of people will get severe infection. Um, 11,000 will need critical infection, and they require ventilatory support, and 23,000 deaths. Uh, uh, you know, possible 20,000, 23,000 deaths in Malaysia if the government uh, is not doing anything. So this was in April last year, just at the early part of MCO. Okay. And then we also presented this one, and where we simulate the effect of, flattening the curve, right? Flattening the curve, and we show that if you do an intervention, for example, the MCO, we would be able to reduce the reproduction number from 3.51 to 1.5. And because of that, we should be able to slow down, okay, not decrease the number of infection, but slow down the progressions of epidemic, so that, the hospital, the primary, the public health people would be able to have time to, sort things out, like, sort the ICU beds, sort the testing, and whatnot. Okay, so we calculated this, or we simulated this in April last year, and we also presented this to the minister. And we show that, by doing some intervention, there will be 80% reduction in the peak, from possible 6 million cases to only 1 million cases at the peak of epidemic. So that, I think impactful, right? People, because when people see this, people will say that, okay, that makes sense. If we do intervention, we will be able to flatten the curve. We can buy some time here, and we can, make sure that the cases are not too many at one point of time. For example, like now, we got 11 cases, 11 case or 15,000 cases a day. It's just one day. If we got 1,000 cases a day, that might be much more manageable compared to 15,000 cases a day, right? Um, we also calculated the effective reproduction number. So this what we have done, and in fact we published a paper in January this year. So we look at the time varying effective reproduction number for COVID-19 and how they relate to each phase of MCO. And this what we got. We show that, during MCO1, between day 1, day 5, day 10, there's a slight reduction in reproduction number. Also MCO2 from day 1, day 5, and day 10. However, for MCO3, the MCO3 things were a little bit relaxed, right? And so we could see that there was an increment of reproduction number from this to this, and then MCO4, not as strict as MCO1, and the reproduction stabilized, reproduction number stabilized. So that could be, one indication that actually the infection during that time, during MCO4, was still, rampant, but, maybe we missed that golden opportunity to really, did an intervention to push really the cases or source of transmission down. Maybe we were a little bit complacent, maybe, okay? Or maybe we were a little bit too optimistic, all right? Because we look here, there was not, the R value is not on the downward trend, it's stabilized. It means that the infections are still happening, last year. We also made a few or developed a few dashboard to help us to quickly look at the trend of infection. For example, this is this dashboard that we host on our server at USM. We look at the trend of infections and death for Malaysia and Southeast Asia countries. So if you look here, this is I think this one I screenshot last night. This for Brunei, they got a little bit of infection there, and this is on the log scale, okay, the log scale. So the log scale is better than the linear scale because the log scale will be able to tell you the rate of infection better than the linear scale. Linear scale will deceive your views, but log scale is a much better way to show whether the infection is on the increasing trend or not. Okay, so if you look here, this is Malaysia, right? This is Indonesia, which is going up. In fact, if you look at Indonesia, Malaysia, and Thailand, the cases of COVID-19 are all going up. All right. But interestingly, that our neighbor Thailand is, the rate looks faster than us. We are a little bit flat there. If you draw a line here, there is a possibility that Thailand, sometime end of this month or maybe next month will overtake us. Okay, will overtake us. And this is one dashboard that was developed by one of our team, Dr. Wan Arifin, also hosted on our server, USM server, where we look at the number of cases, daily cases, death, and also the vaccination status. And we would like to say thank you very much for to the Ministry of Health that has put the data now on GitHub. So now the data of COVID-19 aggregated, unfortunately, not the line listing data, are available from GitHub, which you can easily tarik lah, what we call as tarik, or pull into your software to analyze. In this case, we just let our software uh, extract the data every day automatically, so that it's going to be almost real time. And this is the dashboard that our colleague or our team member also developed, hosted on our USM server, where we look at the vaccination status for Malaysia. And we also would like to say thank you for the um, mostly that make this vaccination data available on GitHub. I think that is very important. Okay, that is very important for epidemiologists to have good data, good reliable data. The more data we have, the better quality data, then the better analysis that we can provide, so that we can communicate this back to policymaker, public health people, so that with that they can plan, or their strategies, and workflow, and intervention, and other things. um, of course, with when you want to model for epidemiologists, for example, like uh, if you want to model disease, right, so you have to got tools for you. Okay, you got to have tools to help you with that. Okay, and one of the software that that is going to be very very helpful for you is the R software. So I'm a big fan of R software, and I'm one of the member of the R user group from Malaysia. And um, our software is open source software. They got thousands of packages that can help statisticians, epidemiologists, econometricians, and other people to help with the data analysis. And for epidemiologists, there are a number of packages that are very very useful. That are being used by the London School of Hygiene and Tropical Medicine, that are being used by the Imperial College, that are being used by IHME. They use the same software, the same models, or the same techniques in R to produce their models. So so what we have now, if you got our software, then you have a very powerful tools to help you with modeling infection. One of the groups that I'm also in is in the Recon group, the R Epidemic Consortium. And so I would like to end this presentation, all right, with this summary. Number one, I think the roles of epidemiologists are important during epidemic and pandemic such as COVID-19. Of course, the role of epidemiologists are always important, right? But epidemiologists are more visible during this COVID-19, right? Before this, not so visible, right? So now people knows who are epidemiologists, and in fact many public health people are interested to further their study in epidemiology. Number two, priorities are different at different phase of COVID-19. Okay, so for epidemiologists, they need to suit the requirements of each phase of pandemics. No, at the early phase of pandemic, what are the priorities? Now we are in the middle of pandemics. What are the priorities? Okay, um, modeling uses COVID-19 data, right? And because of that, very important for epidemiologists to have good, reliable, adequate data. We need to have good data. Without good data, we could not give you back good models. we need to have reliable data, because if they are not reliable, then our model also not reliable or not valid. We need to have uh, more complete data. If data is more granular, then better for us. But no data is perfect. Okay, so because no data is perfect, we have to make lots of assumptions. That's why even though you know we use epidemiologists use the same SIR model, but different teams will come up with different projections or trajectory or forecast, because the assumptions that they use to during the analysis are different data one and different assumptions, different parameters that they set. So you got when you look at the models that epidemiologists have presented or have communicated or you have read, you see that so many models, so many data, so many results. Which one can you trust? That's another problem. Okay, that's another problem. Who can you trust? And then epidemiologists communicate their models to other teams, so that other teams will have will translate the models into action. Okay, we'll translate the model into action, and then come back to us so that we can review our models and improve our model. Um, Again, which model is correct? Okay, which models are correct, or our models are wrong? One famous statistician, George Box, mentioned last time, many years ago, that all models are wrong. Okay, all models are wrong. Very pessimistic. But he says that all models are wrong, but some are useful. Okay, some are useful. So, so that's what we want. Maybe what we want is useful models. Okay, so at least we got useful models so that we can, we can help people to do the control and prevention program. If we don't have models at all, then we don't have anything, So we got to have models, even though we have limited data and other challenges. So I think my last slide is I would like to acknowledge the COVID-19 epidemiological analysis and strategies team and project headed by Prof. Dato Awan Bulgiba and my team, epidemiological modeling team at University Science Malaysia. So that's all from me. I'll pass back the baton to Prof. Madya, Dr. Muhammad Fauzi. Over to you, Prof. Thank you.